Welcome, everyone. We are really glad to have you here at Emory's Dementia webinar series. We meet every Wednesday on the second Wednesday of the month. So every second Wednesday of the month at noon. And the topics that we choose for this dementia webinar series are brought to us by y'all. So please let us know what you want to hear about. Today, we're really excited because my colleague, and I'll tell you a little more about her, but Jenny Gay is going to be talking about transitions outside of the home for a loved one living with dementia. And this is a very hot topic, how you do this, why you do it, when you do it, all of the details that are involved. Want to introduce ourselves. My name is Ashley Varner. I'm a clinical social worker here in the Cognitive Neurology Clinic. I'm accompanied, as I mentioned, by my colleague Jenny Gay, who is the social worker in the Integrated Memory Care Clinic, and Alice Cooper, who's also in cognitive neurology. A couple of housekeeping details for y'all. We will be using, this is a webinar, so your picture will not show up and your camera's not going to work and your mic's not going to work, as is true for all webinars on Zoom. But you can put questions, and we urge you to put questions as they come up in the Q&A section that you can find depending on what device you're using, either at the bottom of your screen or the top of your screen. It says Q&A, and it has the icon that they use is two little thought bubble boxes. So please do let us know what questions you have. This is intended, this session in particular is intended to be very much question and answer oriented. What else did I forget, y'all? Okay. Then without further ado, I am going to introduce Jenny. We are so lucky to have her here at Emory. Jenny Gay is a Decatur, Georgia native, where she grew up attending the Padea School. Jenny then attended Warren Wilson College for her undergraduate education, where she majored in social work. She knew what she wanted early. Jenny's love and passion for working with elders and those living with dementia was ignited during her internship with the Council on Aging of Buncombe County, her senior year in college, where she provided case management for low-income seniors. Jenny spent 3 years as a social worker at Jewish Family and Career Services of Western North Carolina, providing case management, managing a food pantry, and leading an adult day program for elders. Jenny then moved to New Orleans and attended Tulane for her master's in social work and completed her internship with a hospice company. And then we got Jenny back in Atlanta in 2016 after obtaining her master's degree, and she started working as a geriatric care manager at Jewish Family and Career Services of Atlanta, and then went on to become the supportive services manager at Jewish Family and Career Services here in Atlanta. Then we were lucky enough at Emory in 2022 that she started working for the Emory Integrated Care as a clinical social worker. She is one of my mentors, and is just because she's so passionate about working with people living with dementia and their families. And she now resides again in Decatur, where she's from, with her husband and her little boy. So without further ado, I'm going to turn it over to you, Jenny.
Thanks, Ashley. Sorry for my long-winded bio, but thanks for getting through it. It's so nice to be with all of you today, and I'm so grateful to be at the Integrated Memory Care and very, very passionate about our program and our patients and families, and feel really fortunate to be in a role where I wake up loving where I get to come to work every day. It's a pretty good feeling. So good to see all of you. So today, this is a presentation that could have a ton of different approaches and could provide a lot of different types of information. When I was going through it, I really struggled with what I wanted to narrow focus on today. And certainly if there is interest in elaborating on this topic or going to it in more detail or from different approaches, I am absolutely up for doing that in the future as well. I tried to pick a topic that I felt like really resonated with the majority of families that I provide services for here at our clinic, and a lot of the questions that I get. So a lot of my slides are wordy because I'm a little bit of a wordy person. But note, I'm probably not going to just read off of my slides. I'm probably going to pull them up, elaborate on information, and share information with you. And then as we go through it, if questions come up, I'm happy to answer those. And Ashley, if you can just give me a heads up if a question comes up, if I need to pause, and if you can read that question to me, I'm happy to address it.
Absolutely.
But without further ado, I'm going to jump right in. And thank you all for letting me be with you today and give this presentation. So before we jump into the presentation, I find that when I give these kinds of presentations or start speaking with families generally, they look at me with a little bit of a blank stare when I start using some of the terminology that for me is really just second nature. It's stuff that I've been talking about for over a decade in my work life. And, oftentimes I just think people need some really good basic information about some of the terminology that I'll be using today. And so for those of you that know all of this terminology, I apologize in advance, but I wanted to set everybody up for success and understanding. So when we start talking about terminology, so something that you will see come up in a lot of the slides is activities of daily living. Activities of daily living is a huge part of accessing services to services that are provided by different vendors that we work with. And it's something that people really need to have an understanding of, especially as it relates to the dementia disease process, because people's abilities to perform their activities of daily living really change as they move through the disease process. So when we talk about activities of daily living, we are talking about bathing, dressing, eating, toileting, ambulation, and transfers, basically moving around. In this presentation today, you will see activities of daily living spelled out sometimes, and then other times you'll see it abbreviated as ADL. For skilled nursing facilities, there are three different terms that we commonly hear for skilled nursing facilities when we are in this world and talking about different levels of care. So often when we hear skilled nursing facilities, you will see the abbreviation of SNF, which stands for skilled nursing facility. The other two terms you'll hear often are long-term care facilities and nursing homes. All of these three things mean the same thing. And so often when we're talking, you'll hear these different terms and it can just get real confusing. So, and then also we have the disciplines that are present in many of the care environments we're going to talk about today. So registered nurse, RN, certified nursing assistant, CNA, licensed practical nurse, LPN. I went through the presentation. Those are the ones I pulled, but there may be some others. If you have questions, let us know. Caregiver. This is another term that gets confused with a lot of families that I work with, understandably so. So caregiver, this can mean a family caregiver or someone within someone's chosen family system, or it can be a professional caregiver from a home care organization that works in a community setting or someone that's hired privately in the community. And sometimes care partner is used interchangeably with this term. So we've got our terminology all set for us. Okay, so when we start talking about transitions outside of the home, there are a lot of different reasons transitions outside of the home need to happen sometimes. And I also just want to share sometimes, a lot of families start this journey with this disease process and they have a goal of not leaving the home. And so certainly I know myself and the other social workers that provide supportive services to this population, we want to help you meet those goals, but sometimes it's just not possible. And so something I learned a lot about when I came to work at Integrated Memory Care is something called compassionate realism. And sometimes We have to be realistic with people about what is safe, what's feasible, what's affordable, and what's going to be needed as their person moves through this diagnosis and disease process. So the first reason that we will see transitions happen can be for safety concerns. When I think about safety concerns, the primary ones that come to mind are wandering and or eloping, behavioral and psychological symptoms of dementia. So sometimes our loved ones can become violent. They may become very loud. This is not a part of everybody's disease process, but certainly is a part of many people's disease process. So environment factors, so stairs, inaccessibility of a home for an aging process overall. Although not all of our patients are what we would classify as older adults, some of our folks are diagnosed early on in life and have early onset, or a frontotemporal diagnosis that's given early on in life, earlier in adulthood. But those environmental factors of a home are really important to assess and think about when it comes to what is going to be feasible and realistic if someone loses the ability to maneuver stairs. Are there resources to install a chairlift? Is there an option to have them live on the main floor of the home? Is there a bathroom that's accessible? What's going to be feasible? So all of those things come into play. The care needs exceed what can feasibly be provided in the home. So sometimes people may have a hospitalization and may have a new component of their care upon discharge that just can't be safely provided in the home. Sometimes it can be with certain resources that are brought into the home, but sometimes it can't. Sometimes financial reasons are part of why somebody has to transition. A lot, care overall, medical care in general, is very expensive. When we start talking about the types of care people need when they're living with dementia or aging in the home, sometimes getting all of the care somebody needs at home can become too expensive. And for most people, it becomes too expensive. Caregiver medical challenges or aging process. Many of our patients and families are cared for by a spouse or a family member that may have their own medical challenge. That medical challenge can make it very difficult for them to provide direct care. And often these are hard conversations that we have with caregivers and with families, but they need to happen sometimes. So we also want to be looking out for the caregiver's overall health to make sure that they're okay and they're safe in the environment and that this is feasible for them. We also have I separated caregiver medical challenges and caregiver burnout because they are two very different things. So, medical challenges happen. People move through different medical issues and have limitations as a result of that. Caregiver burnout can be a combination and can exacerbate some of those physical symptoms. But caregiver burnout in and of itself is a reason that care is not always possible in the home. So that caregiver who may be living with their loved one, the mental, emotional, and physical tolls of caregiving for somebody living with this disease process are tremendous. And in order to make sure that the caregiver is safe and that the loved one living with dementia is safe, sometimes it's not possible to make everybody's wishes and ideal situation happen at home. So need for community features. Often we have folks living with this disease process who are isolated in their home, and they may have caregivers coming in, they may have family around them, but they really need a place where they can share meals with other people, where they can receive medication administration, where they have activities and abilities to be a part of a community, which we know is really, really good for people living with this disease process. We know that being with people is good for all of us, even though sometimes it's maybe not what we want. We do better when we're with people. So for this presentation and for today, again, there are so many different directions we could take. I really wanted to clarify what residential options for care outside of the home exist. And you have to also keep in mind, depending on where you live, these options vary by state. Sometimes these options vary by county. So in Atlanta, in the metro area, the 10-county metro area, these are the residential care options outside of the home that exist for us. Again, these can vary depending on location. So we're going to go through each of these types of environments. We're going to talk about what type of care is provided in them, what staffing looks like in them. And the one thing I didn't include is kind of what is required on the administrative caregiver end to get into these environments. And we can delve into that a little bit more, especially if people have questions during the Q&A section. So we're going to discuss personal care homes. We're going to discuss assisted living environment, memory care, and skilled nursing. When you are considering placement for somebody living with dementia, some of the considerations are a little more specific than just general placement. Some of these I would say are universal for any type of placement for anybody, but specifically for people living with dementia, I would encourage these to be some of the questions at the forefront of your mind. Does your loved one require a secure environment? Does your loved one have a history of wandering, eloping? Are they really ambulatory? When they are agitated or anxious, what does that look like from a behavioral standpoint? Do they get restless? Do they want to get out? Having that secure environment can allow people to be cared for and have their care managed in a way that's safe for them and prevent them from getting out and wandering and eloping and something bad happening to them. What is the care ratio for direct care staff to residents? This is important for any type of placement you're looking at. We want to see care ratios for people living in senior living that reflect a good quality of care being provided. This is a constant challenge in this industry. And I would say across the board, most communities are really struggling with this because providing care, especially care for people living with dementia, is very complex, very draining. It's a very, very hard job. How long have the direct care staff worked at the community? I think overall, we see better outcomes for people in communities when staff has been present for a longer period of time, when they are part of the culture, when they are invested in the quality of care being provided somewhere. Does the direct care team receive training on how to provide direct care for people living with dementia? This is something that you would be surprised how often this does not happen in communities. A lot of the time people, especially from a marketing standpoint, will share, that, all of our direct care staff learn specifically how to deal with behavioral challenges and how to de-escalate people. And often we get patients in these settings, and in fact, the staff does not have training or knowledge about how to navigate the behavioral symptoms of dementia. And it's not just the behavioral symptoms, it's also how to support people living with this disease process, do as much as possible as they can for themselves safely. So instead of having staff, assume that someone can't do anything because of this diagnosis, do they know how to prompt? Do they know how to cue? Do they know how to make eye contact and use body language that is friendly and non-threatening? There's a lot of things that, I think for us in this field seem very automatic that for people in the direct care field work, a lot of instruction and training can be really, really valuable and really enhance the quality of care provided. What opportunities for meaningful engagement are available for residents? I think this is especially important for people living with dementia because, you don't just want your regular garden variety programming. You want programming that is going to promote cognitive activity and cognitive health, brain health. And so based, depending on what programming is available, what is the frequency of the programming? Are there different types of programming? Thinking about what helps your loved one tick and be successful and find contented space. What activities would they like to do? And talking about what opportunities exist within these communities for your loved one. So these are my slides that are a little bit wordy. And again, I apologize. So the first environment we're going to talk about is a personal care home. So for the most part, there are some outliers, but a personal care home is usually a single family home, a residence that's been converted into a small care environment that provides direct care and oversight to the residents living there. Sometimes this can mean 12 residents. Sometimes this means 30 residents. Sometimes this means 2 residents. All personal care homes are designed very differently and have different capacity. Some personal care homes have people that share rooms. So some personal care homes don't have the ability for people to have individual rooms, and it'll be a shared room automatically. So it just really varies. The license for a personal care home in Georgia is different than an assisted living license. And so a lot of the things that you see reflected in an assisted living environment are very different from a personal care home. Sometimes they can look very similar. Sometimes they can look very different. Sometimes parts of them look the same and parts of them look different. So what is provided in a personal care home? So personal care homes, in essence, were designed to provide assistance with activities of daily living. I think most senior living was designed to assist with activities of daily living. So that means that meals are provided, medication management. Some, not all personal care homes provide transportation to medical appointments or to like stores for people to go shopping. It really depends on the population living in these environments in the specific personal care home, because it may be a personal care home with folks that are non-ambulatory, folks that are, not appropriate to take out into the community or require too much hands-on care to go into the community, or they need somebody with them to go to a medical appointment. So it really depends on the population. Staffing ratios vary. Again, some have single rooms, some have shared rooms, some have private bathrooms, some don't. Personal care homes are kind of the Wild West of senior living in Georgia. There are some that are incredible, and there are some that leave a lot to be desired. So again, I'm just trying to hit some other things. Typically in personal care homes, there's some social programming, and some of the bigger ones, they do a good job with programming. In others, there's not a lot of programming because the team of people working there don't really have the bandwidth to prepare meals, administer medications, provide direct care, and do activities. Some days they may have more bandwidth to do that, and some days they may not. But I would say for the most part, most care in personal care homes is really devoted to personal care and assistance with activities of daily living. Usually staff in these personal care homes include certified nursing assistants. Sometimes they have supervising LPNs or RNs. The owner of the personal care home sometimes has multiple roles within their personal care home. Sometimes they're very hands-off. Really depends. There's a lot of gray area with personal care homes. And we're going to talk about payer sources for personal care homes prior to ending the presentation. The one piece that I did not share in the presentation on a slide is that in order to enter a personal care home, a physician medical evaluation is required, which is a piece of paperwork that is also required for assisted living. It's the same paperwork. So a medical provider has to sign off that you are appropriate for this environment. And most of the time you have to surrender medication administration to the staff. Assisted living. So a community designed to be a home for residents that require assistance with various levels of care. Again, levels of care really come down to activities of daily living and how somebody is able to engage and move through their activities of daily living when they move into a community setting. Residents living in assisted living do not require skilled nursing care. That's a very important thing, and we can talk a little bit more about that. Living spaces can be apartments, rooms, sometimes shared apartments. Sometimes assisted living will have a lot of occupancy that they need to fill, or they want to find ways to make their rates more affordable for people. So they will share suites or rooms sometimes. So assisted living, um, so in order to enter an assisted living, an initial evaluation is completed by the staff at the assisted living. You're also getting a physician medical evaluation completed by your primary care provider or specialty provider based on who you're receiving information from. The focus of care is usually on activities of daily living, but also medication management, housekeeping, meals, social programming and engagement, transportation to medical appointments. Staffing includes certified nursing assistants. Sometimes there's always a wellness director. Sometimes that's an LPN or an RN. There's an activity and engagement coordinator. There's dietary staff, receptionist, concierge, transportation. Again, housekeeping again, marketing and community liaison and executive director. So as you can see, there are some big differences between, from a staffing perspective, what is automatically provided in an assisted living versus a personal care home. Assisted living is a little bit more of a rigorous licensing. And so these roles have to be filled out in order to be state compliant. And so, I would say when I'm working with a family that really wants to make sure that there's strong engagement and social activity happening, if we're looking between a personal care home and an assisted living, it's likely the assisted living may have a more robust social calendar and schedule and a devoted activities coordinator. And so, but it really varies from community to community. And certainly when you're looking at these places, you can ask for a calendar. You can try to examine what's happening when you're there, when you visit. But so assisted living is not necessarily a secure environment. So, and I'll also say that with personal care homes, a lot of them don't have what we would call locked or secure features. So residents are able to come and go freely or access the external exits of the building without a lot of barriers. And some assisted livings do have secure features on their doors and some don't. And same for personal care homes. So you really have to look at that individually. When we start talking about memory care, so memory care is a specialized portion of a community designed to be a home for individuals with various forms of dementia. It is a safe, structured, and secure environment that requires a code and or staff member to access. Most assisted living communities in this day and age have a memory care portion of the community because dementia is such a prevalent condition in our society these days. And this is a need that so many people have as they move through their disease progression. So somebody living with dementia who still is able to participate in some portion of their activities of daily living, but is not a wandering risk or an elopement risk, or doesn't need that smaller ratio or that less stimulating environment, they may do really well in assisted living initially. And then as they move through their disease progression, they need a smaller environment. They need more prompts, cues, support, moving throughout the day with people, a secure environment. Memory care becomes a really feasible option for those people. And if it's present on the same campus as the community they're already living in, that makes things a lot easier for the caregiver and the patient sometimes. So in a memory care, what is provided? So all services that are available in assisted living, so things like assistance with activities of daily living, medication management, meals, housekeeping, those are all included. Memory care communities should provide, hint, the words should, provide specialized programming to meet individual cognitive, social, and emotional needs. Structure and support from staff should be more involved and hands-on than assisted living. So when I'm looking at a memory care, I don't get to do that as much as I used to. But in some of my previous roles, when I would be evaluating memory care environments for my patients or my clients, I would want to know about staffing ratios. I would want to know about the size of the memory care and kind of what the day-to-day looked like. Was it a smaller group of people traveling throughout the day, doing activities, sharing meals together? what that looked like and what the environment itself looked like. A lot of memory cares are shaped in the form of a circle or in the form of like what looks like a neighborhood kind of within the community, so that it is straightforward for the people living there so they can try to be as independent and move throughout that environment in as safe a way as possible throughout the day. So again, I would love if I could say universally that folks working in memory care receive dementia-specific training and education. We're not quite there yet, but I think a lot of people are taking steps to get there. The staff that you're going to see in a memory care environment is the same as you would see in an assisted living. Most communities that have assisted living and memory care on site have separate activity directors. And the intention behind that is that folks living in memory care need a specific type of engagement and programming and activity. And my hope is that the folks doing programming and activities within the memory care have a little more specialized training and education about how to engage people living with dementia. But the biggest difference between memory care and assisted living is that memory care is going to be a secure unit. You've got to have a code to open a door or an area of a building in order to get in, so that people don't get out and aren't at risk of wandering or eloping from the environment. And then last but not least, we're going to talk about skilled nursing facilities, which we talked about are interchangeable with the terms of nursing home and long-term care facilities. One thing I always like to say when I start talking about nursing homes is that not every single person will end up in a nursing home. Not everybody living with dementia will end up in a nursing home. It is a very medicalized level of care that exists within our society. If you need it, you need it. If you don't, there are some other viable options that can sometimes provide a better quality of life, but sometimes it's the care people need. And, it's a harsh reality to face when a loved one needs a skilled nursing environment, but it's also a very needed resource at times. So I'm grateful they exist, but also it's a very tough level of care to provide to people. So skilled nursing facility is an inpatient rehabilitation and medical treatment center staffed with trained professionals that are medical professionals. So when we talk about skilled nursing facilities, there are typically two portions of a community. There is the rehabilitation side. So for example, your loved one goes to the hospital, has a hip fracture, knee fracture, spine fracture. They need short-term rehab to get back to their highest level of functioning. Granted, with dementia, sometimes with our folks, they can't engage in therapies anymore. And so based on where you're at in that trajectory, it may or may not be an option to go to short-term rehab. That's a whole other presentation. But for today's purposes, so when we're thinking about skilled nursing, we have short-term rehab and then we have long-term beds. When I say long-term beds, I mean people that have a medical need that will be required probably for the rest of their lifetime, and they will probably live the rest of their life in a nursing home if they are in a long-term bed. Some nursing facilities, in addition to having the short-term rehab and the long-term beds, within the long-term bed area, there can be dementia-specific care, which can also sometimes be called memory care, which gets really confusing. All of this terminology gets really confusing. And so if there are long-term beds that serve people living with dementia, they may have the ability to have a locked or secure unit like they do in a memory care or assisted living. But memory care in a skilled nursing facility is very, very different from a memory care in an assisted living community. So there's lots of different reasons people end up in nursing homes. It can be short-term rehab, it can be long-term care. It's really based on what you need, but you need to have a demonstration of a skilled need for care. A skilled need can be a feeding tube. It can be a special type of IV antibiotic drugs. It can be a lot of different things. Technically, being classified as a two-person assist meaning when somebody is no longer able to maneuver their body weight or help move, they become classified as a two-person assist. So that in and of itself can classify you for skilled nursing. So the staff at a skilled nursing facility varies from what's provided in assisted living and memory care, because it basically is a very medicalized model of care. There's a medical director, there are nurses, CNAs, there are med techs, social workers, physical therapists, occupational therapists, speech therapists, an activity director, a nursing home administrator, dietary, housekeeping, admissions, reception, transportation. When it comes to transportation and what's provided from a nursing home, that's different at every single nursing home. In terms of getting into a nursing home, the admissions process is much more rigorous and complicated than getting into an assisted living or into a memory care or a personal care home. To get into a skilled nursing facility, you have to find an open bed that accepts the form of payment you have available to you to enter that environment. And so the best time to enter a nursing home from an admission standpoint is when you are in the hospital. If you need short-term rehab, that's a really good gateway, and you can convert from a short-term bed to a long-term bed. Again, nursing home stuff is really a presentation in and of itself. I just wanted to paint the picture of what that environment provides, and who works there and what that looks like. And then I didn't want to leave this off, but there is something also called a continuum of care retirement community. They're also starting to use different language around these types of communities and calling them aging life plan communities. And so this is a type of retirement community. We have quite a few in the Atlanta area, where a continuum of aging care needs can be met. So this means that, and today we didn't talk about this level of care because it's not a level of care where any care is provided. So I didn't go into that, but we have independent living, assisted living, memory care, and skilled nursing all on the same campus. These places also tend to have health centers where you can receive primary care. They kind of operate also like an urgent care clinic on site. They can do a lot. They tend to have very robust activities, multiple restaurants. You know, the caveat for these communities is that they are exorbitantly expensive and they require an upfront admission fee to enter the community. And that fee doesn't go towards any direct care you need while you live on that campus. So in order to enter, we're talking about an investment, and then we're talking about paying for the environment you inhabit while you are there, whether it's independent, assisted, memory care, skilled, and then we're talking about payment for the level of care you require while you're living in that environment. So this is a very expensive type of community, very expensive type of care, but it is another option in our community. So I wanted to certainly make sure that I shared that today in my presentation. When we talk about all of the different environments we have gone over today, these are the ways to pay for them. So when we talk about, for example, you'll see for personal care homes and skilled nursing facilities, you will see the word Medicaid. So in the state of Georgia, Medicaid waiver programs or nursing home Medicaid, which are different things, and also could be its very own presentation in and of itself. Those are the only two environments that Medicaid will contribute towards. So when you see Medicaid EDWP waivers, that is one way to pay for a personal care home placement. The other options are long-term care insurance, VA benefits, and out-of-pocket expense private pay. For assisted living, we're talking about long-term care insurance, VA benefits, out-of-pocket expense, or private pay. Memory care is the same payer sources as assisted living. For skilled nursing, nursing home, long-term care facility, all interchangeable. We've got nursing home Medicaid, which is a type of Medicaid that can only be used in a nursing home and can only be applied for once living in a nursing home. Long-term care insurance, VA benefits, out-of-pocket, and private pay. And the CCRC Aging Life Plan community model can only accept long-term care insurance, VA benefit, and out-of-pocket private pay. One other thing to note is that for CCRCs and aging life plan communities, for the most part, this is not a universal comment, there is a grace period, but for the most part, if they have a skilled nursing facility on site, even for short-term rehab, it is only available to residents of that community. Sometimes there are loopholes and things that can happen when places open, but for the most part, they are not available to the community at large. When you are thinking about placement and you are thinking about care outside of the home, there are a lot of different avenues you can take to get help. So there are agencies here in Atlanta. It seems like every day there's new ones I haven't even heard of. And here at IMC and with cognitive neurology and CEP, I think we have some good relationships with senior placement specialists. These are people that can identify price range, geography, level of care needed, and can work with you to come up with a list, set up tours, negotiate rates, help you, be an advocate for you. There's no cost to use their services because they receive a commission upon placement. Therefore, there are some people that do a beautiful job with this and really do this work because it's meaningful to them and important to them. And there are some folks that may not take that approach. There are people that provide geriatric care management. These are people that can provide a lot of hands-on, very intensive support that can work with placement specialists or can work for you independently to help you find a good community, be your advocate for a lot of things beyond senior living. Medicaid caseworkers, I have this listed because if somebody is utilizing a waiver to enter a personal care home, or it has been in a personal care home on Medicaid and is transferring to a nursing home, that will require the assistance of a Medicaid caseworker, which you are assigned upon receiving those benefits. This is a tool, it's called Compare Nursing Home Quality. Sometimes I am really grateful for this tool. Sometimes I feel frustrated by this tool. You have to take the information that you get from this tool with a grain of salt. You have to take into consideration that this is a snapshot of time. Most feedback you hear about things is negative feedback. And so a lot of what you can see on here can be really scary. At the end of the day, when you're moving about placement for a loved one, whether it's long-term or short-term, I see families get the options and they get on this website and they really spiral to a dark place. And what I will say is it's probably a lot more impactful to visit these places in person and gather your own thoughts and insights rather than relying just upon this tool. But this is one tool of many you can use to evaluate. There are movers specializing in transitions to these settings. A lot, they're called senior moving specialists. So they understand the emotional complexity of leaving a long time home, moving into a community, how to downsize, putting things in storage. And then I also would say, you know, especially for IMC families and for cognitive neurology, I'm not as familiar with the CEP dynamic in terms of social work support, but I know that you can set up individual sessions with any of us and we can talk about your loved one, what your goals are for their care. If it's time to move outside of the home, we can have a really person-centered conversation that is personalized and tailored to you and your needs. If you set up a session, you are much more likely to have this interaction and get as much out of our services as possible. If you're calling or sending an email asking on the fly questions, we sometimes don't have the bandwidth to devote that same level of care and guidance that we do when we get a full session with you. So I would really encourage you to do that. That is all my slides. I'm going to stop sharing.
That is wonderful, Jenny. You did an awesome job. What a great wealth of information that you provided, you know, not just to the people during the session, but also to myself, all of that. Just even how to pay or what separates what in terms of personal care homes and assisted living and who's there. So, so much appreciate that. I did not see any questions right now. So please, 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 this is your time to be able, Tracy has her hand raised. Tracy, are you able to put a question in the box?
It'll need to be the question and answer box.
Yeah. Okay. I'm not quite sure. I don't think this is a question. But
I'm
but
glad you're steering people towards
Yes.
placement, folks.
Yeah.
They definitely have the best
Yeah.
pulse on the landscape of these communities. So-
right. Exactly, because we are not able to do this. So she's asking if the recording will be available.
Yes, it will be available. It may be a couple of weeks. It gets backed up, but we now have a YouTube site with all of the or just about all of the dementia lecture series going back to when we started in 2021. So I will add that to the next invitation that comes out so that y'all can look and see what you'd like to look at again or look at if you happen to miss it.
Big thanks to Ashley for making that happen.
Yes, yes. Marilyn, I see your hand raised. Can you put your question in the chat box? I mean, not the chat box, the Q&A box, please. Are you able to put it in the Q&A?
And I would also just, I see the comment about steering folks to placement folks that you know personally. I think that's a really important point to make. There are organizations out there who are out there to make money off of placement and who make it sound kind of nice because they say, oh, well, you're not going to owe us any money. But it's sort of almost a kickback, if you will. And so they may not be looking for the best placement, but the one that gets them the most money. So just kind of thinking through and asking us, there are some fabulous placement specialists who have a whole different scheme of how that works. And those are the ones that we tend to use from here.
Someone in the question, Betty said, I have heard it's much cheaper if the facility does not have skilled nursing on campus. I'm not aware of that, but Jenny, have you heard that?
I don't know if this is directed at like so a continuum of care retirement community would have to have skilled nursing on campus to be classified as a CCRC. And assisted living and memory care and personal care homes can't have skilled nursing on campus. So I'm a little bit confused by this. Betty, do you want to elaborate for us? I mean, I think the big takeaway is skilled nursing is extremely expensive. No, I don't see any.
Wait, she did.
I did not know that. Okay, I'm sorry if I didn't explain that well, Betty.
Marilyn, are you able to get on the Q&A? I am not seeing Marilyn get on.
I see she left a comment.
Okay. Oh, no, I see it. Okay.
Okay.
Oh, Ashley answered the YouTube about seeing the seminar. All right. If there are no, oh wait, no, Connie. Oh.
Thank you, Connie.
Connie.
5 stars.
Wonderful. Well, if there are no other questions, again, like Jenny said, you can always reach out to her in the IMC clinic, Ashley, myself, and Debbie. in the Cognitive Neurology Clinic, and we will certainly be happy to assist you. Okay? Thank you so much for joining us. Okay, sorry,
Just
Ashley.
quickly mention that Jenny said several times that could be a topic all in of itself. We would love for you, or I would certainly love for you to reach out to me with topics that you're really interested in. If one of those things that Jenny said today that could be a topic in and of itself really piques your interest, please let us know and we will work to get that. This is really y'all's lecture series. We do it trying to get the questions answered and provide y'all with the information you need to provide to make life just as easy as it can possibly be. So so please do let us know what you're most interested in. We are in the midst of developing our calendar for next year, so this is a really good time to let us know. And we will be kind of merging this lecture series with the Caregiver Connection lecture series from the Cognitive Empowerment Program, as well as something from our Georgia Memory Net. So it will be some new topics and some popular topics next year, but we're really looking for what y'all most want to hear about. All right, if there are no other questions, we'll end.
Thank you all so much.
Thank you, Jenny.
Thanks, Jenny.
Bye, guys.